Okay, we're going to get started with our last panel for today. If you could please find your seat. Thank you. All right, everyone. It's time for our final panel of the day, a forward-looking session titled The Path from Mental Illness to Mental Health, Bridging the Gap Through Innovation and Collaboration. This discussion will explore the crucial steps needed to transform our mental health care system, focusing on healing and recovery. Leading this important conversation as both chair and speaker is Dr. Tom Insel. Dr. Insel is the psychiatrist, neuroscientist, and former director of the National Institute of Mental Health. He has been a leading voice in reimagining how science, technology, and community can transform mental health care, and is the author of Healing, Our Path from Mental Illness to Mental Health. Please join me in welcoming Dr. Tom Insel.
Wow, what a day this has been. This has really been great, and delighted to be part of it. Laura, thanks for that introduction. We're going to sort of round out the day by talking about a few other issues connected to what you've been hearing, but kind of now making the jump into talking about healthcare itself. If it's helpful, I'm going to just take 3 minutes and sort of provide some context remarks. And I could have done this at the beginning of the day, but maybe it's even better to do it towards the end of the day here. When we think about this field of mental health, we often start talking about mental health care as soon as we talk about mental health. They're different, but broadly, there's sort of 4 what I'll call buckets in this landscape that are worth knowing about. The first, which is what we talk about most often, particularly in the precision world, is about diagnosis. And there are lots of ways to cut that, whether it's through symptoms or physiological signs like imaging that we've seen, laboratory tests. Also important to know about social context. SDOH is the social determinants of health, which are super important for understanding diagnosis. And maybe most important, but often least collected, are measures of function and how somebody's actually doing, because we know there's a very poor correlation between the intensity of symptoms and the ability to function. Some people with severe symptoms still manage to go to work, and some with very modest symptoms are really disabled. Treatment is the next bucket, which we've talked about quite a bit today, right? It's certainly important to think about not only what the options are, but how they come together. And I listed 5 of them, or 4 of them here, but what I mostly want to stress is the importance of thinking about combinations. We know enough in this field to say 2 things. A, we have treatments that really work, and B, there's no magic bullet, that generally the best outcomes are by combining the treatments that we have. The 2 things we haven't talked as much about that I really want to stress are the importance of setting. And for behavioral health, there are now more settings than ever. And the conversations we've had about AI have raised the whole possibility that this is a do-it-yourself operation as well, and that it's not even clear when and how there will be a human in the loop much of the time. So it's a really interesting moment to think about what is the future of this field going to look like. I'd like to say that AI for mental health could be what DNA was for cancer, really fully transformative of diagnosis and treatment, and changing the field entirely. The part that I most wanted to stress is actually the last column, because we haven't talked much about it. Nolan Williams mentioned this, and it was a really, for me, when I saw his presentation, I thought, going from 6 weeks of treatment to 6 hours, that's pretty interesting in terms of the impact it can have for the actual care system. And the care system in the United States is fundamentally a payment system. So if you want to understand what gets done and how things get translated into care, you have to follow the money. You have to understand what's getting paid for. In this country, fundamentally, if it isn't paid for, it's not going to be adopted, it's not going to be delivered, it's not going to be accessible. And if there's one thing I've learned in 10 years now through 5 startups in the mental health space, probably the most important thing I've learned is that you really have to know who's going to pay for it. It's a question I never asked when I was at NIMH in 13 years and probably $20 billion worth of funding to grants. I don't think we ever asked our grantees, well, if this works, who's going to pay for it? And yet it's really the fundamental question when you think about healthcare, because it is ultimately a transactional piece of this. You could have something really spectacular, but unless it's paid for, it's not going to be delivered. So when I think about these 4 buckets, I think where we're going is for each of them to develop something that's critical that we don't have yet. Precision, certainly for diagnosis, changing the goal of treatment to be around recovery, not just symptom relief, but recovery. And that's what that book I wrote is about. Setting the key here is engagement. And I'll say more about that in just a moment. And then for payment, really defining what is value, something that, by the way, the mental health space has failed to do. Still, there's no consensus about what should be paid for at this point. Just want to quickly make a couple more comments, and then I want to turn this over to the rest of the panel. But I often talk about these sort of inconvenient truths in the mental health space in a way that, for those of you who aren't really in this field, it is fundamentally different than what you would see in cardiovascular medicine, in oncology, in studies with diabetes. I mean, we're really talking about a different world in 3 particular ways. One is that we have a diagnostic system here, so that first bucket is not really connected to the other 3 in any serious way. And that is a huge problem. Now, I'm not trying to pick on the DSM. DSM actually is agnostic to treatment response. It says that in the very first page of the preface of the book, these are categories that were developed without looking at treatment response. One might ask, why would you do that? Because in most of medicine, we try to make the diagnosis relevant to treatment, but in this case, it hasn't been done. And so there's a lot of work to do in this precision space to try to fill that in. It's even, one could say that the purpose of that diagnostic manual is for reimbursement, but it's not even particularly effective for that. The second point, and it's one that's really painful to talk about, is the biggest issue we face in the mental health world in terms of care is that for lots of reasons, people don't buy what we sell. That we have a really massive problem around engagement. More than half the people who should be in care and could be in care and would benefit from care are not. And this is really different than what you'd see in heart disease or in cancer, particularly because in those other parts of medicine, the sicker you are, the more likely you're going to be in care. In mental health, it's just the opposite. So people with mild to moderate disorders might be seeking care at a very high rate. Those with the most severe disorders are running away from care and avoiding it at all costs. That's a hard problem to solve, but it's one that we have to solve if we want to really have an impact. And the third point is that very few patients in our world are involved in research. Now, virtually every pediatric cancer patient in the United States is in a protocol of some sort. And I can tell you that virtually no pediatric mental health patients are in any protocol of any sort. That's a problem for us, and it's a problem that we need to solve if we're going to make progress. We have to be able to connect the worlds. It's sort of interesting to me that we're having this great conversation in this room with so many brilliant people here at Stanford, but Stanford's also a healthcare system with tens of thousands of patients, and the healthcare system is not really in this room. And I think a challenge for us and an opportunity for us is to begin to invite the healthcare system to feed and to work with and collaborate with the academic medical center in a way that benefits everybody. So I've been involved with, and I'm just going to take a moment to say this, with a new entity. It's a public benefit corporation called Benchmark, right now just in Massachusetts, working mostly with Harvard. But what we're trying to do is to fix a bunch of those problems by creating a different kind of care system that's all based on every individual looking for mental health care, getting an advocate. In this case, it's a licensed social worker with a lot of AI agents on the side who help that person to find the very best care. Usually it's online, sometimes it's offline, coordinates that care, and they stay with the person all the way through the journey. They're not just an advocate, they're a Sherpa, and they measure outcomes, and they use those outcomes to actually generate what we're calling a precision navigation tool that's based on seeing how thousands and tens of thousands of people are responding to the interventions that are out there and learning as we go. It is a learning health system, and it's one that I think is a model for how this can be done. What we're going to do in the next few minutes is to hear from some experts who are thinking about each part of this. So we'll start with Bill Martin, who's going to help us think about getting to the diagnostic precision that we need. Then from Anagati, who's going to talk about how do we actually get the adoption of innovation into healthcare. And then finally, and I'm really excited about this, we have Brandon Staglin with us to talk about how do we involve patients in research? How do we get not like less than 10%, but more than 90% of people who become our partners in research? So we'll start with Bill Martin. Bill is the Global Therapeutic Head of Neuroscience at J&J. I'd like to point out that in this last 20 years, when almost every pharmaceutical company has left the study of mental illness and the development of drugs for mental illness, J&J may be the lone exception to that rule. They have stayed the course all the way through. Bill leads that effort for discovery and development of a precision neuroscience pipeline, transformative treatments for neuropsychiatric and neurodegenerative disorders. Bill has a broad experience. Some of you will have known of his work at Blackthorn Therapeutics, where he was president and CEO. It was a company that was acquired a few years ago by Neurawell Therapeutics. He previously worked at Theravance and at Merck, where he was shaping the neuroscience franchise. He's active in the brain health community, serving on the advisory council for Brown University's Carney Institute and the National Academy's Forum on Neuroscience and Neurosystem Disorder within the National Academies of Science, Engineering, and Medicine. He's a founding board member of the Alliance for AI and Healthcare, authored more than 80 peer-reviewed articles. Bill, thanks so much for joining us.
So humble to be here. Thank you, Tom, for that introduction, and thank you to the organizers for including me. You know, as I started the day, I thought, oh, well, this is going to be fantastic. Surely no one will cover the content that I'm going to cover. And then, of course, throughout the day, everything that's in my slides has been covered. So for those who have been here throughout the day and feel like maybe a good recap was necessary, consider my opportunity with my talk. For those who don't need that recap, take 10 minutes to get a little nap. Your brain probably needs it. So I want to talk about the promise of precision neuroscience. And this is an example of what you would have seen before. By now, you recognize the heterogeneity that we're talking about in many of these categorical diagnoses of serious mental illnesses, conventional approaches. You've heard about trial and error. The promise of the precision approach is that we can develop treatments or identify treatments that take into account features of the patients and their disease. And I think this is an important statement. We're often talking about going from disorders to diseases. And by that, we mean that there's underlying biology that's governing the dysregulated behavior. And the idea is that through the advances in biomarker discovery, would say data science, which is both ML and AI, and clinical trial innovation, maybe we can move toward these more precise therapies. And this is not to say that experience as medicine is not a viable possibility. It is. It's not to say that we shouldn't look at non-pharmaceutical approaches, neuromodulatory approaches. We should do that as well. But I do humbly submit that we do not simply have a matching problem. We do not have enough pharmacological diversity to address the array of symptom challenges, symptom domain dysregulations that we're seeing. So part of what we've been trying to do, thank you for recognizing, Tom, I inherited this legacy. Johnson & Johnson has had a continuous commitment to neuroscience, medicine discovery and development for 70 years, 7 decades. And it continues through the setting of a lot of failure. What we're trying to do is actually now establish, with this revolution in AI and ML, new framework for thinking about pharmaceutical development. So this is that why, and Tom mentioned this as well. I do think we have a problem here. It's a marketing problem, if you will. When you're talking about major depressive disorder, as we heard a little bit today, these are diseases that are potentially fatal and left untreated will lead to death. And many of us have experienced this firsthand. For that, I'm sorry for all of you. But this is not the way we approach the problem. We approach the problem thinking about, well, we just need to sort of start treatment, and then we're going to hope for some response, and then that response is going to be sufficient. And the reason why we're in a trial and error paradigm is because, frankly, it's not that expensive. It's not that expensive to use generic medicines, and we'll go from one to the other and we'll monitor. But it's very expensive if you think about the life-threatening aspect of failure. So part of the systematic shift is to say the promise of precision is not just in getting the right treatments to the right patients at the right time. That's, of course, true. The opportunity is saying that the residual symptoms that are present after sort of a primary treatment, they tell us something about the biology that's being unaddressed. And if we can learn more about that biology, I've talked about some of the sources of residual symptoms, anhedonia, this inability to experience pleasure from things that should provide joy, sleep disruption, anxiety, fatigue, you'll know all these things. The question is, can we identify those underlying elements, those domains, their biology that's governing that, and actually come up with better ways, new ways of treating these symptoms. So this is something that maybe you haven't seen, but I think does put into the context everything that you've heard about today. And I think it's really useful because we talk about AI, we talk about diagnostics and prognostics, but do we really talk about how we connect one to the other to arrive at a ground truth, to arrive at the disease within the disorder, the biology that's governing the behavioral dysregulation? So one way to think about this, you've heard a lot about brain measures. I think that is a ground truth, functional imaging, EEG. We've talked about clinical symptoms. They will always be there. This is actually probably going to be our guiding force. And there were questions, but we haven't talked too much about fluid measures. And you can think about each of these sort of sides of the triangle, the linkage of clinical symptoms to brain biology as giving mechanistic insights into these diseases. You can think about the relationship between brain measures and fluid measures as a way of maybe more simply getting to a diagnostic that's truly scalable. With all due respect, when you talk about 25 million people in the US and hundreds of million people across the world, which is where we're trying to develop our therapies, we need something that truly is scalable. And the last part is, of course, linking those clinical symptoms, to, for example, the fluid measures, to a diagnostic measure that can give us the confidence to proceed. So what we've done, and in the most part, we're focused on developing medicines, but in some cases, I noted the clinical trial innovation, we have to embrace and sometimes develop technologies to support that. So I'm giving you this 3 examples done alone or in collaboration. The one is this reward learning application. This is basically a gamified system inspired by Adam many years ago. Hey, could we actually index the brain and brain circuitry related to anhedonia, simply by developing a task. You're a ranger, you're going to actually, quantify the number of red parrots and blue parrots. And of course, there's a bias in there in terms of reward, and we're able to detect reward learning differences and show that those correlate to the symptoms of anhedonia. That's one of the examples we've included in one of our trials. The other is one that you also saw presented earlier today, the emotional processing bias task. This is using at facial recognition. And the critical part here is, how can we actually more simply and reliably recognize this emotional bias dysregulation within the context of testing novel pharmacology? And that's something that we have deployed in one of our trials currently as well. New pharmacology, muscarinic M1 receptor antagonist, looking at a rapidly acting response to symptom relief. And then the last one is sleep monitoring, where EEG, you can do it lots of different ways. We've done it various different ways. Here, highlighting one that this is the sort of now with Beacon Technologies, trying to have a scalable EEG solution to get to the sleep aspect. I'm going to spend some time, last couple of minutes I have just on this. As you know, 80% of patients who have depression actually suffer from sleep disturbances. And those disturbances, even when you correct the sleep, you don't correct the depression. However, we know that at a brain circuitry level, work done actually here at Stanford some time ago, has linked the orexinergic system and the brain circuits there to not just the regulation of mood, but to the regulation of sleep. And we've shown with one of our selective orexin 2 receptor antagonists, seltorexant, that in fact you can reduce the symptoms of depression in an adjunctive setting. That means they're already on background SSRI, SNRI therapy, and show only in those with depression and insomnia symptoms do you improve with a orexin 2 receptor antagonist. Otherwise, the treatment looks just like background. So this is an example of developing the measures to develop the new medicines to advance the concept of precision. I will end here because and Tom, the last thing I thought, well, certainly no one's going to cover this, but Tom has covered this beautifully. We have to begin when we think about, from the conventional approach to the precision approach, between here and there's a lot of there to go. And you have to begin with the end in mind and really work backwards. So we think really simply, I've used this in the context of the seltorexant and insomnia within the setting of depression. You think not only about approval, but also about access. Will someone pay for this because it's sufficiently differentiated, addresses a problem? And then ultimately, adoption. Can the healthcare system actually incorporate this into the overall path? And with recent experience we and others have seen in the world of Alzheimer's disease, by the way, the adoption component cannot be underestimated. So even when you achieve new disease-modifying therapies, new fluid-based measures for diagnosis, it does not mean physicians will adopt them, even if payers pay for them. So with that, I will yield my time and look forward to the panel.
Thank you, Bill. The next remarks are from